Oral cancer. The term cancer means crab. Neoplasia is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of normal tissues and persists in the same excessive manner after the cessation of stimuli which evoked the change. Carcinoma is epithelial tissue origin. Sarcoma is mesenchymal tissue origin. Chondrosarcoma originates from chondrocytes and osteosarcoma originates from osteocytes. Oral squamous cell carcinoma. Oral cancer is defined as a malignant neoplasia which arises on the lip or oral cavity. Oral cancer is the 6th most common cancer in the world and 10th common cause of death worldwide. High rates of oral cancer are reported in India. Oral cancer represents 4% of all cancers in males and 2% of all cancers in females. The age group is people older than 40 years are usually affected by oral cancer. But nowadays, it is of high concern that many young age group people are affected by oral squamous cell carcinoma. The etiology, habits like tobacco, alcohol, and arecanut are primary etiological agents for the development of oral cancer. Tobacco and alcohol plays a synergistic effect. The other factors include nutritional deficiencies like vitamin A deficiency, trauma, sepsis, sharp teeth, exposure to sunlight, viruses like human papilloma virus, herpes simplex virus 1 and herpes simplex virus 2. The risk factors include male gender, older age group, tobacco and alcohol, and atrophy of oral mucosa. Pathogenesis. Carcinogenesis is a genetic process that leads to change in morphology and cellular behavior. 2 types of genes are involved, proto-oncogenes and tumor suppressor genes. Proto-oncogenes increase cell growth and differentiation. Tumor suppressor genes negatively regulate cell growth and differentiation. Functional loss of tumor suppressor genes occur in carcinogenesis. The current model of carcinogenesis is a multi-stage process with loss occurring on chromosome arms 3p and 9p early in the lesion's progress from benign to dysplastic. Coming to the presenting signs and symptoms, discomfort is the most common symptom. There will be an awareness of a mass in the mouth or neck. In advanced disease, dysphagia, odynophagia, otalgia, limited movement, oral bleeding, and neck masses are usual symptoms presented by the patient. The common sites are buccal mucosa, tongue, oropharynx, floor of the mouth, and gingiva. The high-risk sites for oral cancer include lower lip, anterior floor of the mouth, lateral borders of the tongue. The tissue changes. Red, white, mixed red and white lesion. Change in surface texture. It may be smooth, granular, rough, or crusted lesion. There will be a presence of a mass or ulceration. You have to carefully assess the cervical and submandibular lymph nodes. This picture shows carcinoma involving various sites in the oral cavity. The first picture shows CA involving the tongue. You can see the left lateral border of the tongue. There is an ulcer with a granular surface and an everted edge. The second picture shows carcinoma involving the hard palate. That is, the left side of the hard palate shows an ulceroproliferative lesion. You can see the mixed red and white lesion also. The third picture shows carcinoma involving the buccal mucosa. You can see an ulceroproliferative lesion with an everted edge. And the fourth picture shows carcinoma involving the lower lip. Spread of squamous cell carcinoma. The primary spread of squamous cell carcinoma occurs by local infiltration, by invasion of the soft tissue, perineural spaces, and bone. Metastasis, lymphatic spread to regional lymph nodes, and blood-borne metastasis to distant organs. The lymph nodes usually involved are submandibular, digastric, and upper cervical nodes. The lymph nodes will be enlarged, firm to hard, non-tender, and fixation to the underlying structures. This is a TNM staging for oral cancer. T involves the primary tumor, N indicates the nodal involvement, and M indicates the distant metastasis. Coming to the diagnostic aids, early detection of malignant lesions is very important. A thorough head and neck and intraoral examination should be done. The diagnostic aids include imaging and light technologies, vital tissue staining using toluidine blue, computer-assisted cytology of oral brush biopsy specimens. What is toluidine blue staining? Toluidine blue is applied directly to suspicious lesions or used as an oral rinse. Positive retention of toluidine blue in areas of leukoplakia or erythroplakia indicate a need for biopsy. Toluidine blue predicts oral premalignant lesions at risk of progressing to squamous cell cancer. It provides a guidance for selection of biopsy site. Computer-assisted analysis of oral brush cytology. Pap-stained exfoliated cells are scanned by computer for abnormal cell morphology and keratinization. Final diagnosis based on standard histomorphology criteria. There will be 100% sensitivity and no false negative results. PC light is a disposable chemiluminescent light source optical spectroscopy system. Provides tissue diagnosis in real time, non-invasive and in situ. This clinical in vivo fluorescence discriminates normal mucosa from severe dysplasia. Acquisition of tissue specimen, standard biopsy techniques, fine needle aspiration, and exfoliative cytology. Even though there are various methods for diagnosis, biopsy and histopathological examination is a gold standard in diagnosis for oral cancer. Coming to the imaging, routine radiology, panoramic radiography evaluate bone involvement. Computed tomography, magnetic resonance imaging shows bone involvement and extent of soft tissue lesions, status of cervical lymph nodes. Ultrasonography is used for evaluation of salivary gland masses and assessment of lymph node and lung carcinoma. Nuclear CT scanning is a functional imaging modality for oral cancer. Positron emission tomography using the radio-labeled glucose analog 18-fluorodeoxyglucose is again a functional imaging. PET-CT is used for staging of recurrent squamous cell carcinoma. Coming to the treatment of oral cancer, the principal objective is to cure the patient of cancer. The choice of treatment depends upon cell type and degree of differentiation, the site and size of primary lesion, lymph node status, the presence of bone involvement. Surgery and radiation are used with curative intent in the treatment of oral cancer. Chemotherapy is an adjunct to radiation and surgery and is now the standard combined therapy in management of advanced disease. Technical advances like IMRT, that is intensity modulated radiotherapy, reduce the size of the high dose field of irradiation and limit the exposure of adjacent vital structures, including salivary glands. What are the indications for surgery? Surgery is indicated for tumors involving bone, when side effects of surgery are expected to be less than radiation, tumors that lack sensitivity to radiation, recurrent tumor in areas that have previously received radiotherapy. In palliative cases, to reduce the bulk of the tumor and to promote drainage from a blocked cavity. Example, maxillary antrum. Care should be taken that adequate surgical margins are required. Surgical management of clinically positive cervical lymph nodes is also done. Radiation therapy. Radiation kills cells by interaction with water molecules in the cells, producing charged molecules that interact with biochemical process in the cells and by causing direct damage to DNA. The affected cells may die or remain incapable of division. Due to a greater potential for cell repair in normal tissue than in malignant cells and a greater susceptibility to radiation due to the higher growth fraction of cancer cells, a differential effect is achieved. The biologic effect of radiation depends on the dose per fraction, the number of fractions per day, the total treatment time, and the total dose of radiation. Radiation therapy treats the disease in situ, avoids the need for removal of tissue. It's a treatment of choice for T1 and T2 tumors. What is hyperfractionation of radiation? Radiation therapy is delivered in daily fractions for a planned number of days. The relatively hypoxic central tumor cells are less susceptible to radiotherapy, but may become better oxygenated as peripheral cells are affected by radiation. More differentiated the tumor, the less rapid will be the response to radiotherapy. Exophytic and well-oxygenated tumors are more radiosensitive, whereas invasive tumors with small growth fraction are less responsive. Squamous cell carcinoma that is limited to the mucosa is highly curable with radiotherapy. Coming to the types of radiotherapy. Brachytherapy and external beam radiotherapy. Brachytherapy, the radiation therapy may be administered to a localized lesion by using implant techniques. In external beam radiotherapy, the radiotherapy is given to a region of the head and neck and protect the adjacent uninvolved tissues. Brachytherapy. Interstitial and intracavitary implants may be used to treat primary cancers in the head and neck. Brachytherapy may be the primary treatment modality for localized tumors in the anterior two-thirds of the oral cavity for boosted doses of radiation to a specific site or for the treatment following recurrence. The isotopes used include cesium, iridium, and gold. Directly implanted sources may be used to deliver radiation, or an afterloading technique may be used in which the radiation source is placed by using previously inserted catheters or guide tubes. Now coming to the innovations in radiation therapy. IGRT, image guided radiotherapy, CCRT, concurrent chemotherapy and radiotherapy, and IMRT, intensity modulated radiotherapy. Now let us see this in detail. Image guided radiotherapy, in which integrated CT guides changes in radiation throughout the course of treatment as treatment causes change in volume of tumor during treatment. Concurrent chemotherapy and radiotherapy and IMRT are becoming the standard modalities of treatment now. Intensity modulated radiotherapy or IMRT uses radiation beams of varying intensity, which provides the ability to confirm the prescription dose to the shape of the target tissues in 3 dimensions, reducing the dose to surrounding normal tissues. During the optimization process, each beam is divided into small beamlets whose intensity can be varied so that the optimal dose and distribution are obtained. IMRT is ideally suited for head and neck malignancies in close proximity to critical structures, including the brainstem, optic chiasma, and salivary glands. Conclusion: early diagnosis and management of oral cancer is an important factor in prognosis of the disease. The dental professional plays an important role in the early detection and diagnosis of oral cancers. Appropriate oral care requires an understanding of the disease in close communication with the oncology team. Thank you.